Hi, welcome to my 490 presentation. I did my research project on the impact of utilizing a turn team for Q2 turn patients to reduce hospital-acquired pressure injuries on a cardiac intermediate unit. First, we're going to start with the introduction. So what is a HAPI? It is a hospital-acquired pressure injury. They are common and preventable inpatient injuries associated with immobility, moisture, and medical devices. The prevalence, according to a systematic study across many hospitals, showed that upon admission, patients had a 5.2% rate of HAPIs and then left the hospital upon discharge with 12.3%. The incidence of HAPIs is 4.5 to 78.4% of new cases that develop among patients at risk. Preventing HAPIs can be inexpensive and can take a team of people to help pitch in. So target nursing solutions. So in the hospital setting, there are many patients that are unable to move themselves and need to be turned every 2 hours to rotate which area of their body is taking the pressure. When nurses have multiple patients, there can be poor communication between CNAs and PCTs and nurses, and patients can end up going hours without being turned. An intervention that was researched is a turn team. This has been implemented before in many ICU settings and nursing homes, but it hasn't really been studied on what it looks like in a IMU/med-surg floor. The theoretical framework used was the Dorothea E. Oram self-care deficit nursing theory. So this states that patients' ability to care for themselves, if there is a deficiency in that ability for the patient to care for themselves, the nurse comes along and fills those gaps. So self-care is a patient's ability to perform self-care activities, and when there is a gap, the nurse takes over. This theory provides a framework that how the nurses can fill those gaps. The literature review that was done, some themes that were seen was dedicated turn teams improving consistency. So among some studies done in ICU and nursing home settings, units that implemented this turn team had a lower HAPI incidence rate. Education and workflow support matters. So nursing staff, education, visual reminders such as clocks, whiteboards. I have an example of something related to like a turn team schedule. The third theme is bundled interventions with support surfaces. So what this looks like is combining that turn team schedule with use of pressure redistribution devices, specialty beds. So the gap in literature, as discussed before, was this turn team has been implemented on maybe a smaller unit setting, ICU, high acuity, low nurse to patient ratio, but it hasn't really been studied on, and also nursing homes when there's a lot of PCTs and CNAs but not as many nurses, what that looks like on like a cardiac IMU setting, and then kind of what that looks like on a med-surg setting when nurses have 4 to 5 patients, and how this looks turn team wise. So the proposed study is to evaluate implementing a dedicated turn team model on an IMU unit focusing on pressure injury reduction and cost outcomes. So the research design will implement a pre-post test design on a cardiac unit. In the study, the cardiac IMU inpatient unit will implement turn team interventions. This could benefit in the real-world hospital setting where randomization may not be possible. And the pre-post test design are commonly used in research to evaluate changes in a clinical setting. So the research question that I proposed is, among adult inpatient on a cardiac IMU, does implementing a turn team compared to just standard nurse care reduce the incidence of HAPIs over a 6-month period? There we go. Setting, sample, and criteria. So this is a 39-bed level 2 trauma center, Southwestern Virginia, called Central Hospital. The adult patients admitted to the cardiac IMU will be the sample size, and the cardiac IMU will implement a turn team using CNA, nurse-CNA, or nurse-nurse teams. Inclusion criteria: adults above 18, admitted greater than 72 hours, and a Braden score of less than 18. exclusion criteria, those with stage 2 to 4 pressure injuries upon admission, ICU, and those on a hospice care status. So outcomes and measures. So this will be, the primary outcome will be a decrease in incidence of HAPIs on a cardiac IMU. The Braden scale will be used to predict pressure sore risk, validated, and this is a widely used tool. The evidence-based in order to put a number to the patient's risk, and the cardiac IMU will implement turn teams, as I discussed before, CNA, nurse, nurse. Secondary outcomes will be nursing compliance, repositioning using chart audits, and satisfaction and low workload impact by a post-intervention survey. Study procedures, all patients admitted are automatically enrolled. Intervention delivery, those different teams. There will be a pre-test to where baseline pressure injury rates and Braden scores will be collected for 1 month. Then the interventions will be implemented for 6 months, and then a post-test survey will be done to see nurse satisfaction. This is an example turn team schedule. As you can see, this is a larger unit than what I'm working with, but as you can see, there's turn team 1 and turn team 2. As you can see, for the 7 o'clock hours, you would turn your patients with your who you were giving report to, so that would be your second person. And then, as you can see, there's turn team 1 and then turn team 2. So turn team 1, say for the 11 o'clock hour, we have Katie and Derek. So they would go around and turn all the patients on team 1, which is in that left-hand column, 42, 46, 48, 72, 76. And during that 11 o'clock hour, Beth and Cece would also be going and turning the second team of patients, 53, 54, 55, 57, 74. Kind of depends on how many Q2 turn patients you have. If there is enough to just have one team, you would just have one team. Depending on the unit, they can make this how they need to. Ethical considerations, the study protocol will be submitted to the hospital institutional board to ensure compliance with ethical standards for researching and involving human participants. Informed consent would be given and permissions by various people such as unit managers, nursing leaders. The all patient data will be de-identified and stored under a password protection system. There's a couple limitations to the study. The first limitation is that it is a non-randomized study design. The second limitation would be the short study duration, 6 months. That might not be enough time to get all the data that we need. And the third limitation would be staff compliance. So we know that units have an ever-changing staff compliance. So this turnover rate may decrease the staff compliance with that Q2 turn team. Maybe we don't have enough people who are able to do the teams, and it could get a little messy. And these are my references. Thank you so much.